going through. I'll be going through the strategies for a safe lap cholecystectomy. So if you start with the basic things in lap cholecystectomy, this is the most common general surgical procedure, and with
Sir, you are on mute, sir. Please unmute yourself.
Yeah. Mute. Am I audible?
Yes, sir. Now you are audible.
Okay, fine. So to have a safe performance of laparoscopic cholecystectomy, it is important to go through the important anatomical landmarks, some which will help us in doing a safe lap cholecystectomy. And this anatomy of the bilivascular system is very important to have a safe navigation for doing lap cholecystectomy. And you have to keep in mind that this procedure is done in a very critical area where there are important structures like portal vein, hepatic artery, and hepatic biliary system. And if someone understands these anatomical landmarks and the variations, he can easily navigate for going through a safe lap cholecystectomy. Most important area in this region is described as hepatocystic triangle. And this is a target area for dissection during lap cholecystectomy. This hepatocystic triangle is bounded by above inferior surface of liver, below by cystic duct, and medially by the common hepatic duct. And this is the area where our dissection starts for lap cholecystectomy. And in this triangle lies a cystic lymph node, which is an important landmark for cystic artery. And this cystic artery is usually dipped to this lymph node and divides close to the gallbladder. In original description of callous triangle, the upper boundary is the cystic artery instead of the inferior surface of the liver. This is the landmark of the hepatocystic triangle. This is the inferior surface of the liver. This is the common hepatic duct and the cystic duct. And cystic artery is the content in the hepatocystic triangle. And if you take the callous triangle proper described by Callots, is the upper boundary is a cystic artery. Okay, this is the area of hepatocystic triangle. However, while doing surgery, you'll find there are some situations where this anatomy may get distorted, particularly patient having cirrhosis. Or you see, there is this area near the fundus is puckered, is known as puckering sign. And in some conditions of acute inflammation or chronic inflammatory disease, this area may get fibrosed and there may be alteration in this area of hepatocystic triangle. Next is important to know there are some surgical planes of dissection where we are doing lap cholecystectomy. Cystic pedicle. Cystic pedicle is the structures which are exiting from the gallbladder and entering it. These are the cystic duct and the cystic artery. And they are lined by two layers of peritoneum reflecting from the lesser omentum. So cystic pedicle is the target area for our dissection. And this is the area where you find this is the area of cystic duct and this area of cystic artery. And you find there is a lymph node around there. And this is the anterior layer of peritoneum and posterior is the posterior peritoneum. So cystic pedicle is the cystic duct and artery invested by two layers of peritoneum. Then another important structure is the cystic plate. This is a fascial sheath at the liver bed where the gallbladder is located. And this fascial sheath is continuous with the liver capsule. Posterior medially, this cystic plate thickens and joins the fascial sheath of the right portal pedicle. With the gallbladder in situ, we cannot see the cystic plate. As you reflect the gallbladder from the bed after dividing the cystic pedicle, you can see the cystic plate and you can see the clear fibrous band between the gallbladder and the cystic plate. This is the cystic plate. As you reflect the gallbladder, you find there is a fine layer of fascial sheath in the bed. This is described as cystic plate. So while doing cholecystectomy, we should not bridge this plate. So this fundus and most of the body remains closely adherent to the cystic plate. And while dissecting the gallbladder, remain close to the gallbladder rather than going through the cystic plate into the liver parenchyma. If you bridge the cystic plate, there may be two problems. First, there will be troublesome bleeding for the liver parenchyma. And secondly, there might be some post-op bile leak. So we should confine our dissection in the plane between the gallbladder wall and the cystic plate. However, in small contracted gallbladder, the cystic plate may get shortened. while doing fundus first technique in some difficult situation, you should keep in mind that you should be keeping very close to the gallbladder wall, not breaching the cystic plate. And as you go down, this medial side, the posterior medial side of the cystic plate is closely adherent to the right portal pedicle. Another important landmark while doing lap collection is the rubeoid sulcus. Sulcus is a groove 2 to 5 centimeter long, present in the right lobe with junction of its caudate lobe. Is visible in almost 80% of cases, either partially or fully. And the importance of the sulcus is, deep to the sulcus rise the right posterior pedicle or its branches. This sulcus is better seen when you retract the gallbladder neck towards the umbilical fissure, up and towards the opposite shoulder. So initial dissection has to be kept guided by this rubeoid sulcus. So this rubeoid sulcus is another important landmark from where we can draw a line from the rubeoid sulcus to the umbilical fissure. And once you draw this R4U line, this is described as a safety line. And all dissection in the hepatocyst triangle should be confined above, superior and anterior to this line. Because if you remain away from this line superiorly, you are not close to the portal pedicle. So if you go again to this picture, you find this is the rubeoid sulcus and this is the umbilical fissure. And if you draw a line from the rubeoid sulcus to the umbilical fissure, you find this is the area, superior and anterior area to the rubeoid sulcus is a safe area for doing your dissection. One should not go down. We'll show in the next picture that this is the area which is described as safe area for starting your hepatocystic triangle dissection. So this R4U line demarcates the safe and dangerous zone of dissection. And if you see the next picture, you'll find this red area. This red area is a dangerous area which is below and which is inferior to this R4U line. So your dissection should be starting beyond the rubeoid sulcus, above, superior to this R4U line. Another important landmark for safe calcium is the umbilical fissure. Where is the umbilical fissure? The fissure between the left lateral section segment 2-3 and the medial section segment 4. Here lies the falciparum ligament. This is a fixed anatomical landmark. When there is some distortion of the anatomy here, you can easily see the umbilical fissure where the ligament teres goes. And in difficult situation, you can reorient yourself. And this is an important landmark where you will find that you have a safe navigation to the area of hepatocystic triangle. Again, this is the area. You see, this is the segment 4, and this is the falciparum ligament. And this falciparum ligament is ending in a fissure where the ligament of teres is entering. And here lies the segment 3 duct. So this is the important landmark where you have a safe navigation for identifying anatomy in difficult situations. Another important landmark for doing a safe lap calcium is the segment 4 of the liver. So this is the part of the left lobe we described as a medial section of the left lobe of the liver lying between the umbilical fissure and the gallbladder. The base of the segment 4 acts as a fixed landmark. As the dissection in the hepatocystic triangle should be done kephalat to this line, as you draw the line from rubeoid sulcus to the base of the segment 4 after the ligament of teres, the line superior to this is a safe area for starting with dissection. However, there are some congenital conditions like segment 4 hypoplasia or active gallbladder may alter this area. There are a lot of variations. While doing lap cholecystectomy, you should be prepared to understand that all biliary anatomy are not same, and the biliary anomalies are very common, and one should be very conversant with different biliary anomalies before you dissect, clip, and divide something. So if an unfamiliar surgeon is not conversant with these variations, he might end up with injuring the biliovascular tree. So what are the important vascular anomalies in this area? Cystic artery and the right hepatic artery are the two important vessels which are of concern during lap cholecystectomy. Cystic artery is usually single in almost 80% cases. It originates from the right hepatic artery. It traverses the hepatocyst triangle behind the common hepatic duct and supply the gallbladder by dividing into anterior and posterior. Somebody described as superficial and deep branches. So what are the important variations of cystic artery? It can vary in origin, in number, or its course. So this cystic artery can run anterior to the hepatic duct in about 17-18% cases. It can be very short cystic artery where there is a bend of the common hepatic or the right hepatic artery, and cystic artery is very short entering into the gallbladder. It can be multiple cystic artery. An accessory cystic artery may arise from the gastroduodenal artery. And sometimes cystic artery may lie inferior to the cystic duct. So you have to keep in mind that there are some variations of the cystic artery. So these are the important variations. You see, commonly it comes behind the common hepatic duct. It can be double cystic artery. It can be cystic artery coming from the gastroduodenal artery. This cystic artery can run anterior to the common hepatic duct. Cystic artery can rarely come from the left hepatic artery. And cystic artery may divide into number of branches instead of 2 branches. So these are the important variations cystic artery one should keep in mind. So what is the clinical importance of appreciating the cystic artery anomalies? If you are not conversant with a very short cystic artery, which is arising from the a hump of the right hepatic artery or the common hepatic artery, you may injure the right hepatic artery. And you have to keep in mind that you have to dissect the cystic artery close to the gallbladder, and cystic lymph node is an important guide for that. Most of the time, cystic artery around the gastrointestinal artery does not run to the hepatocyst triangle. It goes into the gallbladder below the cystic duct. So if you find a cystic artery which is lying below the cystic duct, this is likely to be an abnormal cystic artery around the gastrointestinal artery. So you have to keep in mind that in that case, you may not get an artery in the hepatocystic triangle, or it can be an accessory cystic artery coming from the gastroduodenal, and you have the normal cystic artery coming from the right hepatic artery. This is another important artery which might get injured while doing lap cholecystectomy. There are important variations of right hepatic artery. Most of the time, this right hepatic artery runs behind the common hepatic duct before it enters. It can be sometimes an aberrant, either a replaced or accessory right hepatic artery. Often can lie on the right of common bile duct. So you should always keep in mind that what we describe in common anatomy is bile duct to the right, hepatic artery to the left. But in some rare instances, this replaced right hepatic artery may lie to the right of common bile duct. So these are the different variations of the hepatic artery. So it can be a hepatic artery coming from the superior mesenteric artery. So it can be a hepatic artery which is lying to the right of common bile duct. So what is the clinical importance of this replaced right hepatic artery? In replaced right hepatic artery, it may appear as a large cystic artery. And if you are not appreciating that this artery will be going back to the right of the liver, you might injure it, taking it as a cystic artery. This right hepatic artery may take a tortuous course in the hepatocystic triangle. It is described as a caterpillar hump or Moynihan hump, and gives a very short cystic artery before it goes into the right of the liver. So this aberrant course of the right hepatic artery makes it prone to injury during the cholecystectomy. Then this biliary, extrahepatic biliary system is another important area where there are a lot of anomalies. The normal force into a lung and 2 to 3 millimeters in diameter. And this cystic duct joins the common hepatic duct at an angle of about 75. In about 75% cases, it ends in an angle. However, this right hepatic duct, which has got a short hepatic course and joins the left hepatic duct to form the common hepatic duct, These are the normal anatomy we see in the portal area. But there are a lot of anomalies of this. So what can be the different variations in cystic duct? If you see this picture, you'll find that this is the A is the common terminal cystic duct. Cystic duct may terminate into the accessory right portal pedicle or right posterior sector pedicle. Cystic duct make a very long course running parallel to the bile duct. Cystic duct in the terminal part may become adherent to the part of the common bile duct either by inflammatory adhesions or by fibrous adhesions. Cystic duct area may get dilated because of a impacted stone, and this might impinge on the bile duct, resulting in a condition called Miliary syndrome. So what is the clinical importance? Unless you are very conversant with this variation, you will not do a safe lab cholecystectomy identifying the cystic duct and the artery. If cystic duct is not apparent during cholecystectomy, either it is short or it is faced by the stone, or you are dealing with a situation of Miliary syndrome. So you need to have a proper care during dissection of the hepatocystic angle. And in some situations where you are not conversant and cannot find the cystic duct properly, you need to adopt to some bailout technique. Do not assume that patient has got a double cystic duct. This can be either a common hepatic duct or bile duct with a short or absent cystic duct. So in this difficult situation, one might need to see the biliary either with a intraoperative cholangiography or by using an indocyanine green. If you find the cystic duct is dilated, think twice before you clip it, because cystic duct dilated as much as 5 millimeter may be a tented common hepatic duct or bile duct. So if you are not able to occlude the cystic duct by a simple medium clip of LT300, you should think twice before you clip and divide it. And you have to display the critical view of safety before you clip and divide. Sometimes anomal or low insertion right sectoral duct, especially when the cystic duct joins it, will put this sectional duct into risk of injury. However, if you achieve a good critical view of safety, you may avoid this injury. So while doing lap cholecystectomy, if you are prepared with situations, there are some pointers which indicates that this lap might be difficult. So in that case, you need to prepare yourself for proceeding with the lap cholecystectomy. You might need some extra instruments. You might need some help of seniors. So in these cases, you should be prepared to either to convert or go for some bailout technique. So what are the predictors of difficult lap cholecystectomy? If you go to the history of this patient, easily we describe the male gender patient has more difficult lap chole because they don't come to the doctor at the beginning, they have pain and then number of attacks. Male gender is one important factor for difficult lap chole. Age more than 65 years. If the patient is presenting with acute cholecystitis, particularly patient presenting more than 72 hours of the onset of pain, patient has previous multiple attacks of biliary colic, patient has previous history of acute cholecystitis, patient has upper abdominal surgery, patient either has a previous failed attempt at cholecystectomy or last time patient had an bailout technique of cholecystectomy. When you examine the patient who are having a high ASA score, patient is having Charlson comorbid index, morbid obese patient having fever, jaundice, or inflammatory lump in the right hypoglycemic region are the important patient who might pose a difficult situation. And there are some defined conditions where you'll find definitely the lap chole is going to be difficult, like Miliary syndrome, cholecystoenteric fistula, cirrhosis of liver or isolated portal hypertension, or patient having a portal cavernoma around the portal hepatis. A laboratory parameter of a high WBC count and raised CRP is important predictor of difficult cholecystectomy. And if you go to the investigation-wise, a normal gallbladder thickness is less than 3 millimeter. Any gallbladder having a thickness of 4 or 5 millimeter is a thick wall gallbladder, might be an inflammatory lesion, is a predictor of difficult cholecystectomy. Small contracture Distended gallbladder with impacted stone, the gallbladder retract. Gangrenous gallbladder Meniere's syndrome, cholecystoenteric fistula, cirrhosis, they are all demonstrated in ultrasound, might while doing surgery, even intraoperative, you can predict that this is not a simple cholecystectomy, this is a difficult gallbladder. You find the gallbladder is shrunken, and when you go in first, you cannot see the gallbladder. Everything is frozen with some omental additions or gut additions. Sometimes you find that there are some depression or puckering of the liver near the fundus. This is a predictor of difficult area of difficult surgery. You find that hepatic angle, you cannot delineate the clear peritoneal window. There is a lot of dense adhesions. Wherever you're touching, there is bleeding and Meniere's syndrome. So there are some situations where you can predict the difficult gallbladder starting from history, taking a good history, doing a good physical examination, having some lab parameters, having some imaging pictures. One can be easily prepared that this might going to be a difficult cholecystectomy. And you find that there are a lot of changes locally in grade 2 and grade 3 of acute cholecystitis. And these are the patient. Again, once you do a surgery, you should be always ready to identify and treat any post-op complications. So there are some predictors of higher incidence of post-op complications. If the patient has got a previous cholecystostomy, the other patient has got difficult cholecystectomy, you may have more of post-op complications. Patient having previous abdominal surgery might have some access-related complications. Patient with diabetes, patient with a CCI more than 6, patient undergoing surgery with a bilirubin more than 2, patient having dilated bile duct, patient has a perforated gallbladder, and patient undergoing surgery in grade 2 and grade 3 acute studies. You should be prepared that these are the patients who are at high risk of having post-op complications. So you see, these are the some of the difficult gallbladder. Where you go in, you cannot see where the gallbladder is. You see, there are a lot of omental additions, there are inflammatory additions, wherever you touch that it might bleed, there may be local perforation of the gallbladder. So once you are going in, you can predict during surgery, this is a difficult gallbladder surgery. And if you go to some, there are a lot of scoring system, but there are some defined scoring system where you can assign a score. So if we go to the cholecystitis severity, from that, there is a score given by Walsh rate of emergency surgery, where there is a score of 10. And if you calculate this individual score and place it, and you'll find that they have predicted the risk of conversion to open cholecystitis based on the G10 score. Conversion can be as high as 33%, having a G10 score of more than 5. However, this depends on the expertise of the surgeon. So if people are getting more and more conversant, they are getting more and more trained. So this incidence of conversion is going down. It's not that high. But you can at least predict that this surgery is going to be easy, moderate, difficult, or extremely difficult based on the scoring system. So based on this background of anatomical variations of the biliary tree, some changes because of the inflammation or underlying disease, and based on the prediction of difficult cholecystectomy, if you're now proceeding to cholecystectomy, how do you select patient for lap chole? You see, this is the gold standard treatment for gallstone disease. So all symptomatic gallstone disease patients are the candidate for lap cholecystectomy unless there are some other contamination based on the patient general fitness. And selected cases of silent gallstone are the candidate for this. So to execute a safe lap cholecystectomy, one need to go through basic steps of lap cholecystectomy. You need a proper retraction of the gallbladder. You need to dissect the area of hepatocystic triangle to achieve the critical view, and need to divide the cystic duct and artery after you have achieved CVS, after you have gone through the concept known as timeout. And then while dissecting the gallbladder from the bed, keep in mind that you will not be breaching the cystic plate. So how do you create pneumoperitoneum? The first step for safe personal lab coli is creation of a safe pneumoperitoneum. This pneumoperitoneum creation can be either by open or a closed technique. And there are a lot of techniques for creating the pneumoperitoneum. And there are a lot of studies in literature with the advantage and disadvantage of different techniques. However, you'll find that a bowel injury. So the complications are almost similar based on the different techniques. So surgeon has to pick up a particular technique and follow in his day-to-day practice. So how do you create pneumoperitoneum? It can be a closed technique using a Veress needle. It can be open Hassan technique. One can pass a 10 millimeter trocar directly into the umbilicus. You can go in by using a OptiView trocar, where as you go into the different layers, you can see the different layer. As you penetrate the peritoneum, you can see the peritoneum. Or if the abdomen is having a previous surgery, you can follow a different area. You can go to the palmar's point and create pneumoperitoneum. So these are the different ways you can create pneumoperitoneum. So what is Hassan technique? In Hassan technique, you make a 1 centimeter subumbilical or maybe a supraumbilical incision. Subcutaneous tissue is dissected. The umbilicus is lifted up. This umbilical pillar, you can see now, is fused to the linea alba. And here, the linea alba, the peritoneum, all are blended together. So an incision is made in the midline at this junction area. And either with your finger or using hemostatic forceps, you try to create an opening in this area of fused linea alba with the peritoneum. And you can see the peritoneal cavity under your vision, and take a blunt trocar and introduce this trocar into the abdomen. So this is the open technique where you make an incision either supra, intra, or infraumbilical, dissect the subcutaneous tissue, expose the junction between the umbilical fold and the linea alba, make an incision, and then create a opening either by your finger dissection or by hemostat and pass a round cannula. So what is the closed technique? In the closed technique, you create the pneumoperitoneum by using a Veress needle. You hold the Veress needle like a dart, and if the patient is non-obese, you can hold this needle at a 45 degree abdominal wall and pass it directly towards the pelvis. If the patient is obese, there is a large abdominal wall. In that case, you can directly go 90 degree to the abdominal wall. And while passing the needle, you try to appreciate the clicks. The one click is going to the linea alba and second is to the peritoneum. If you can appreciate the click, you understand that you're in the peritoneal cavity and the needle has got a safety device. And there are a number of ways you can confirm that needle is in the peritoneal cavity, either by pushing saline, by drop test, and the final test is connected to the insufflator machine. When you connect this to the insufflator machine, the internal pressure should be showing below 10. If you have a situation that the pressure is showing as 11, 12, or 14, you're not in the right place. You have to revise. So this is how you do a closed entry. You steady the lower abdominal wall and then pass the needle either by 45 degree angulation or at 90 degree. And then confirm needle is in the peritoneal cavity and start insufflating. And then while insufflating, keep in mind that the initial insufflation should be slow. You should keep this insufflator machine set to 1 to 2 liters of flow per minute at the beginning, because if you insufflate rapidly at the beginning, there might be a compartment syndrome. There might be compression of the IVC, and patient may have cardiac changes, or even sometimes patient may have cardiac arrest. So keep in mind that the initial setting of the insufflator should be 1 to 2 or at maximum 3 liters. This is practiced by a lot of surgeons. People who are conversant, they claim that they can do a safe entry by using a direct. But as a beginner, one should not try to attempt this technique, because if you make an injury, a very small injury will be a small point tip. If you make an injury with a direct trocar entry, it will be a massive injury and you might land up with a lot of problems. But again, this is a described and established technique of creating pneumoperitoneum. So you make a incision through the umbilicus or below or above as per your practice, and then you take a 10 millimeter trocar, and by twisting movement, you can introduce this. You see, you make the incision, steady the abdominal wall, and then gradually you push this trocar and appreciate the loss of resistance. And at that point, you should stop. What is an optibute trocar? Optibute trocar is a special trocar where you can introduce a telescope into the trocar, and as the telescope traverses the abdominal wall, you can appreciate the different layers of the abdominal wall in the TV monitor. So this allows you to see the different layers of the abdominal wall. As you penetrate peritoneum, as you go to the peritoneal cavity, you can appreciate that your trocar is now in the peritoneal cavity. And then we draw this spike and carry on with your surgery. So this is the optibute trocar. Is a costly trocar. This comes with a price. And as you go by twisting movement, you can see the different layers, and then you find that it is penetrating the peritoneal cavity. So that is how a optibute trocar helps you in creating a safe pneumoperitoneum. And Palmer's point. This is a area where there is least adhesion. If you go to the abdomen for a previous surgery, either by midline incision or by fenestrial incision, most of the adhesions are in the midline. So if you select a point, and this Palmer point is an area where usually you draw a line between the tip of the 9 costal cartilage and the umbilicus. And this is the point which is described classically 3 centimeter below the left costal margin at left mid-clavicular line. Or this can be a tip of the non-costal cartilage to the umbilicus, medial 2/3 and lateral 1/3. So that is the area where you can create a safe pneumoperitoneum, provided you have palpated the abdomen, that there is no splenomegaly, and always ask the anesthetist to pass a Riles tube to empty the stomach. So these are the 2 things you should keep in mind while going to the Palmer's point. So this is the Palmer's point where you can go with a safe varus needle entry, and then you can create pneumoperitoneum, and then using a 5 millimeter telescope, and then you create the other portion. So the next step, once you have created the pneumoperitoneum, okay. Am I audible? Okay. So once you have done this ports, you are ready to proceed with the actual dissection of the hepatocystic triangle. So these are the standard 4 ports for lap cholecystectomy. The camera port in the umbilical area, the right hand working port of surgery in the epigastric port, the left hand working port of surgery in the right mid-clavicular port, and the fundus port is the region of the anterior line at the level of umbilicus. So the next important part for safe surgery is retraction and dissection. You hold the outward and upward. The infundibulum or the neck of the gallbladder is retracted by a grasper and it downwards and laterally. That means caudal. This opens up the hepatocystic triangle. Now you can appreciate the area of callous triangle or hepatocystic triangle, where you find the 2 layers of peritoneum covering the cystic duct and the artery. So this is the retraction you're talking of. You should retract the fundus of the gallbladder towards the right shoulder, up and out. You retract the infundibulum area of the gallbladder towards the down and laterally, and this opens the hepatocystic triangle. Do not push the hepatocystic Hartmann's pouch upward. This will occlude, narrow the hepatocystic triangle area. Then how do you start the dissection? As we have already described that we have anatomical landmarks. We have clear navigation for going through this surgery. So dissection should start at the safest area. With proper retraction, the cystic pedicle is stretched up. Either you can use a hook or you can use a Maryland forceps. So the first thing to do is first incise the peritoneum above the R4U line. And it is a common practice and a safe practice to start the dissection first posteriorly and take the dissection up towards the lower third of the gallbladder. Anterior dissection is usually done after the posterior dissection is done. So this is the posterior dissection. You can either use a hook, and as I said, you always start posteriorly and go up to the lower third of the gallbladder, and that creates a better critical view of safety. First, dissect the posterior peritoneum, dissect the loose velar tissue posteriorly, and then come to the anterior dissection. And once you do the both anterior posterior dissection, you can clearly see the cystic duct going to the gallbladder and the cystic artery. You need to clear some more areas. You see, this is the lower third of gallbladder where you can see the liver. So while dissecting, you have to dissect the hepatocystic angle area, and keep in mind that while dissecting, the previous dictum was for the surgeon to dissect the cystic duct and the bile duct junction. But this practice is changed for 2 reasons. One is, if you are trying to dissect the cystic duct hepatic junction, you might injure a vertical vessel running along the 9 o'clock of this bile duct, which is the artery supplying the bile duct. So it is not necessary to find the junction between cystic duct and the bile duct. It is enough to find the junction between the cystic duct and the Hartmann's pouch junction. That is a safe area for dissection. You not injure the artery going along the bile duct. Always keep in mind that while doing a lap cholecystectomy, hug the gallbladder. Don't dissect away from the gallbladder. Even in an easy or difficult situation, remain close to the gallbladder. If you are doing adhesive lysis, the one time is adherent to the gallbladder, divide the adhesion close to the gallbladder wall. While dissecting the callous triangle area, remain close to the gallbladder wall. While dissecting the gallbladder from the bed, remain close to the gallbladder. So what is critical view of safety? Critical view of safety is described by the Strasbourg, and it is now a standard of care for doing lap cholecystectomy. And there are 3 criteria to achieve a critical view of safety. The cystic duct and artery is dissected, and hepatocystic triangle area is cleared of fat and all irregular tissue. The common bile duct and hepatic duct, you can see, but you should not strip it off. you should not strip the peritoneum from the common bile duct and hepatic duct. As you dissect the cystic duct and hepatic granule area, you can see the common hepatic and bile duct lying medial to that. The lower one-third of the gallbladder is dissected free to expose the cystic plate. So these are the three important structures you might demonstrate while achieving the critical safety. And only two structures should be seen entering the gallbladder, that is the cystic duct and artery. And what is doublet view? As you hold the gallbladder down and outward, you can see the two structures. You lift the infundibula upward, and from the posterior side again, you can see the two structures in the gallbladder. So this doublet view gives you an idea that you have done an adequate dissection of hepatocystic triangle and you are safe to now clip. So if you achieve this critical safety during lab cholecystectomy, the risk of biliovascular injury will be minimized. And one should develop this culture of developing and demonstrating the critical safety to his assistants. And one should be following the timeout before you clip. Once you dissect the cystic artery, you take a pause, timeout. Tell to the assistant that this is a cystic duct, this is cystic artery, this is a lower third cystic plate. And once everybody agrees, yes, we have achieved the critical safety, you are allowed to clip. So this is the clear view of critical view of safety, where you demonstrated the cystic duct and artery. You have, this is the lower third of the gallbladder, and you can see the two structures, the common hepatic and bile duct lying medial to this. So to attain the critical view of safety, you have to spend time, you have to dissect close to the gallbladder, and you have to demonstrate these two structures entering into the gallbladder. So what is critical view of safety? It is not the dissection technique. Critical view of safety is the final view one achieved at the end of hepatocystic triangle dissection. And this is important. This is required for every lap cholecystectomy and before you clip and divide the cystic duct and the artery. These are the three components we already discussed. And as you already talked about this, that we did not delineate the junction of cystic duct and bile duct. Better delineate the gallbladder neck and cystic duct junction. Delineate the lower third of the cystic plate and find only two structures going to the gallbladder, cystic duct and cystic artery. And once you have done this area of dissection, you find out that you have a clear and posterior view of this critical view of safety. What are the limitations? We all say that, yes, critical view safety has to be do the division, but there are some difficult situations, particularly acute cholecystitis, where critical view safety may not be achievable. The callous triangle area may become inflamed or frozen. You cannot dissect, cannot identify the structures. Lower third of gallbladder may become densely adherent and not easily separated from the liver bed. So this area is frozen. In that case, if you have a situation like this, you have to resort to some bailout technique. One important bailout technique is doing an intraoperative cholangiogram. This was earlier routine. When the lab chole started, it was recommended that every patient has to have an intraoperative cholangiogram done through the cystic duct. Again, it has been shown the subsequent studies, the injuries of bile duct has not been minimized with this intraoperative cholangiogram, because often the injury occurs while you are trying to do the cholangiogram itself. However, if you have landed up with a difficult situation where you suspect there is an anatomical variation, where you suspect there has been a bile duct injuries, it is prudent to have a intraoperative cholangiogram to identify this anomaly and the bile duct injury itself. And with the advent of this ICG imaging, now you can demonstrate the whole biliary tree by injecting ICG at the beginning of lap cholecystectomy, provided you have a compatible imaging system. So this is the ICG imaging where you have injected the ICG intravenously, and you can see this ICG in the bile duct and cystic duct. You can easily identify. There is no question of misguiding. So this is the common hepatic duct, this is a cystic duct, and the area of hepatic angle. So once you have this imaging system, this allows you to have a safe navigation for this. And you have to follow timeout before you clip the cigar. What is timeout? And while doing timeout, you reorient, reassess. You have dissected, now you stop. And then once you have demonstrated these two important structures going to the gallbladder, let the assistant agrees, and then you reconfirm and clip and divide. So once you have demonstrated this critical view of safety, you can clip the artery and the duct. By convention, you always say that you clip the artery first, divide, and then clip the duct and divide. It is a good practice to remove the gallbladder endo bag, because some infected gallbladder might lead to some higher incidence of port infection. So you can use your customized bag made out of gloves, or there are some conventional endo bag available in the market. You can use that. So once you go through this, as I said, there are some situations where you have some complications during the performance of laparoscopy. So there are some strategies for minimizing biliovascular injuries. These strategies are proper training. You have to use optimal. You have to understand the relevant anatomy. You have to identify the factors for predicting difficult lab query. You must follow some stopping rules. That means at some point you have to stop, wait, reassess, and then proceed. And in most difficult situation, you must follow some bailout technique. And never forget that you often need a help of another surgeon while doing difficult laparoscopy. So execution of correct technical technique is important for safe performance. Achieve critical view of safety in almost 20 cases. Use energy sources judiciously, and understand the stopping rules. If possible, do an intraoperative or at least a ICG imaging where doing a laparoscopy and you have the gadget in hand. So how do you minimize a bile duct injury? There is a concept called look for, be safe. If you go to these words, you understand what be safe means, and you identify these structures while doing the cholecystectomy. B means bile duct. Bile duct lies at the right free margin of the porta. S is the sulcus. I've already talked about you have a rubeate sulcus, and you should always keep your dissection superior to the sulcus. A is the hepatic artery, and this hepatic artery pulsation lies commonly to the left of bile duct. But as I said, sometimes this can make it a hump coming in front of the bile duct. It can be a short cystic artery. In difficult situation, find the umbilical fissure. That is the important guide. From the umbilical fissure, if you draw the line and you remain superior to this line, you are unlikely to injure the portal structures. Sometimes duodenum or other enteric structures may become adherent to the gallbladder. Keep in mind that you may have a bowel coming adherent to the gallbladder. In that case, you need to divide and clear it up. There is another concept known as segment 4 approach. In severe acute cholecystitis, CVS may not be achievable. In that case, follow another line, which is called as D line. And this D line can help you bail out, and it can be a vectoral landmark, particularly in patient who has got a callous triangle. What is this segment? You see, this is the segment 4. Okay. This is the dorsal anterior part of the segment 4. And this is the ventral base of the segment 4. So draw a line from this dorsal segment 4 to the base of segment 4 and come like this. So if you have a frozen callus, go in the line between the go in the line between this attachment of the falciform ligament. This is the anterior and superior part of the segment 4, and this is the base of segment 4. So draw this line like this and don't go below this line. You see, this is a segment 4 approach, where you have this segment 4, and as you draw this line, you always find the Hartmann's pouch is below this. So as you come dissecting, and this can be made free easily, you can go up to this point. Or in some situations where you have a frozen callus, you have a Hartmann's pouch densely adherent, you can bail out with a subtotal cholecystectomy. This is segment 4 approach. You see, the difficult callus, which nothing is seen. In that case, follow this line. Don't go below this. So what are the different bailout techniques for a lap cholecystectomy? This has been compared to a flight situation. If you are traveling in air, you will find that they have a standard protocol to take off, navigation and landing. In bad weather, pilot may after some time may decide that he is not going to take off. So flight may be cancelled altogether. And until weather improves, he will not fly. However, he has started the flight, and in between, he has landed up with a inclement weather en route. What are the options? This is all your experience. He may choose to return to the source of origin. He can come back. He can fly around bad weather and reach destination somehow. Or he can divert the flight to an alternative destination. So these are the options left to him. So the primary aim is what? For the pilot, the primary is the safety of his passengers. He is traveling with about maybe 150, 200 passengers. So it's not the reaching destination is important for him. For him, the safety is important. Same with the lap cholecystectomy. You are doing a difficult lap cholecystectomy. The patient is under your knife. So your idea is not to complete the cholecystectomy anyhow, injuring bailout, injuring arteries. You say your aim is to having a safe lap cholecystectomy. So what are the bailout techniques? You can abort the procedure. You come back, don't proceed. You convert to an open procedure because you are not conversant doing a difficult lap cholecystectomy. You cannot identify the anatomy in the hepatocystic angle area. It's all inflamed. Whatever you're touching is bleeding. You can do a deep cholecystectomy. While coming down towards the hepatocystic angle area, this area is frozen. You can land up by saying that I will do a subtotal cholecystectomy. Or you cannot start dissecting the Hartmann's pouch area. You can decide to do a fundus first or doom down cholecystectomy. So these are different bailout techniques which are available with a surgeon while doing difficult. So bailout technique is required in difficult anatomy when difficult callus angle dissection result in biliovascular injury, and avoid going with a complete cholecystectomy. So convert, abort, tube cholecystectomy, subtotal, fundus first. So aborting the procedure is a good decision, but you have to keep in mind that you have to abort before you have not gone to a phase of no return. Patient is bleeding. Patient is having biliary leak. You cannot abort. You have to address the situation. This is a safe technique. If you cannot separate the gallbladder, there is a lot of adhesions, there is a lot of vascularity. In that case, patient is having empyema gallbladder. You can do a tube cholecystectomy while doing laparoscopically. So you just pass a tube through the fundus area, you take the stones out, take the pus out, and come back. So it can be just a tube cholecystectomy. In difficult situation, you can decide to convert, but keep in mind that even after conversion, the chance of biliovascular injury is there. So you have to follow the safe technique while after even conversion to this. In fundus first technique, you are not comfortable with the dissecting the hepatic cystic angle area. In that case, resorting. But you keep in mind that this is also not a 100% safe technique. It should be conversant and it should be remaining close to the gallbladder. And if you go to the different techniques of a fundus first cholecystectomy, you should keep in mind that these are the patients who might have some injury to the right hepatic portal pedicle. You see, in fundus first, you bring the fundus down, bring the Hartmann's pouch area down, and if you can go up to the cystic duct, you can get that. Or if you decide that you cannot dissect the area of cholecystecal area, you can do a subtotal cholecystectomy. And what is timeout? As I said, that timeout is a practice one should follow before you divide the cystic duct and artery. Timeout is a practice you should do before dissecting hepatocyst angle to find any of these anomalies you can look at the beginning. And for a safer operation, it is important that entire surgical team to be cognizant of this concept and adhere to basic principles on a regular basis. And we already talked of Be Safe, where you identify the important landmarks and try to identify those structures during surgery. And this is another important area of safe laparoscopy where you are using energy sources. Some people are using advanced energy sources, but keep in mind that a simple monopolar and bipolar cautery is good enough for doing a safe laparoscopy. But inappropriate use of diathermy can result in capsular coupling, may result in gut injury, may result in biliovascular injury, and these are usually a late presentation. While dissecting with a cautery, you decide about what instrument you are comfortable with. Many people use a hook very nicely, and while using hook, you should use the tip and go by short burst of diathermy. Ultrasonic shear has got some advantages. There is less thermal spread. And patient having a frozen area, you cannot use the ultrasonic shear for dissection because these blades are not that curved. Some people can use this energy source to divide the cystic artery without clipping. You see, the ultrasonic shear is an important addition where you have a lot of additions, you have a lot of difficult situation. This can help you achieve good hemostasis with minimal lateral thermal spread. Two tubular center in the gallbladder. You have to stop and review what is that. You find there is a large cystic artery. So before you clip a large diameter artery, taking a cystic artery weight, stop, review whether it can be hepatic artery or not. You find there is a large pulsation behind the presumed cystic duct. So this can be a common hepatic duct. Because of the hump, this duct is shifted. Medium large key fails to occlude the cystic duct lumen. Wait, review. This can be a dilated cystic duct or it can be a tented common bile duct. There is a lot of fibrofatty tissue around the hepatocyst angle area. Don't try to clip in that situation. Okay? You are doing lap cholecystectomy, the gallbladder is not opened, but you find a fresh drop of bile in the operative field. You keep in mind that something might be wrong. So in that case, stop, review, and then proceed. You are doing dissection and anesthesia is saying that there is more bleeding. There is a lot of bleeding and patient is now having hypotension, requiring blood transfusion. Stop. Stop, review, and think of bailout. It is not an unwise decision to call help for another person helping you in difficult situation. So if you are having a difficult gallbladder, unusual anatomy, poor progression, in spite of a lot of time being spent, always call for help. And keep in mind that misidentification is a major cause of biliary vascular injury. Most commonly, the tenting of bile duct is identified as a misidentified cystic duct and may result in injury. In 10% cases, hepatic artery is identified as cystic artery. Keep in mind that a wide artery is not cystic artery. If you are in doubt, always call for help from second person. He might guide you in a particular difficult situation. Another important aspect of safe laparoscopy is the documentation. While doing surgery, if you have a system for recording, record all the procedure. If not, you should keep everything in writing. What was the difficulty, what you followed. And this documentation is important to identify further injuries. This document is important to predict whether this patient can develop any post-op complications or not. And while describing this documentation, if you have a difficulty, you try to describe what has been done to go through this difficult situation. So in conclusion, biliary injuries after lab chole can result in significant morbidity. Surgical team involved in lab chole should be aware of the concept of culture of safety in cholecystectomy. The universal culture of safety should be routinely adopted by the whole surgical team during every case. The key component of the concept of safe laparoscopy is summarized in this concept: following the anatomical landmarks, following the anatomical planes. So a clear understanding of the relevant anatomy is important. And in difficult situation, the bailout techniques. Try to obtain critical view of safety prior to division of cystic artery in every case. Recognize the importance of timeout. If facility is available, use ICG imaging while you dissect the external biliary. Always try to have a second opinion in difficult cases. Always document the intra events. In addition, surgeons should be able to anticipate the operative difficulty based on previous pre-op factors. Adhere to basic principles of surgery, including safe use of energy devices. Must confine dissection to the safe zone of dissection with the help of R4U line or D line. Thank you. So any question? You have gone just 10 minutes beyond because there is some technical hitch. Any question? Any question or you'll conclude? Yes, Dr. Indra, you want to ask something? Okay. Thank you.